let's start my presentation, which is as an introduction as an entrance for my presentation is a question. Is it aesthetic full mouth rehabilitation or it's a treatment? I mean, is it the only aesthetic approach or it is a combination between aesthetic and treatment? To answer this question, I'm going to share some clinical cases very quickly. This case, 2015, came to my clinic. He was suffering of the anterior central incisor, lateral incisor, the right one. Then we did some 4 laminate veneers. After a few years later, he came back with this situation, the grinding. So at that time, we suggested for him the case should be full mouth rehabilitation, but he selected only 4 anteriors. So later on, we decided to take the whole package, full mouth rehabilitation, and that was the result. So in this case, the full mouth rehabilitation is not only an aesthetic improvement, it is a treatment before the aesthetic. Another case, she came to our clinic with a lot of complaints after 2 years of porcelain laminate veneers. She has a lot of bondings in her veneer, sensitivity, gingival inflammation, and many of the other concerns that she was complaining about. And we did pie tracing. It means full mouth rehabilitation. Unfortunately, we get it's one of the most successful cases. That was before and after. Another case came to my clinic. She had only 10 upper and lower veneers, but the case was indicated for the full mouth rehabilitation. So before coming to our case story from the previous cases, we can share that full mouth rehabilitation almost is the treatment before being an aesthetic modality. So what we are doing, we are treating the case, then at the end, also respecting the rules of the aesthetic, we will get the case with the combination of the aesthetic and treatment. So they both are integrating together, and could be set up with a treatment plan. So I can say most of the cases, if we select the case well, they are treatments before the aesthetic improvement. Then I am coming to explain some principles according to our time frame, about the full mouth rehabilitation. Fortunately, I have a full case story for you to explain the whole story and step by step what's important based on our times. Ms. Hiba came to my clinic. She was complaining of some hidden sources that she wasn't aware of the issues. For example, she was having a huge amount of gingivitis, calculus, and she was concerning the aesthetic improvement. But after inspection, and you will see in the upcoming slides, she was complaining of many functional, biological compromising. But the only reason that she was trying to improve, she was seeking to improve, was aesthetic. Fortunately, we could diagnose the case well, then we could improve aesthetic and function together. Here, it is worthy to be said, case and patient, she does not come to you, they are not coming to you and telling you, oh, my TMJ is harming me. They are hurting us and I want to be fixed. They are coming mostly for an aesthetic issue, for an extraction, for some visible or let's say common problem, but we have to diagnose them. So how we can set up our diagnosis? We have to start through 4 main points. First, ask our patient, what is your chief complaint? Of course, they are answering us. Our chief complaint is only aesthetic. But when we come to the case, when we, let's say, to start our diagnosis, we have to focus on the foundations of the treatment planning. For the foundation, I would like to focus on the 4 pillars of treatment planning based on the facially generated treatment planning, which is firstly stated by Frank Spear, how to correlate between in the full mouth rehabilitation between the extraoral landmarks, intraoral landmarks, then how to respect the function, how to preserve the structure, and also how to protect the biology. They all should be oriented from the facial. It's called facially generated treatment planning. So the first one is the aesthetic, the first pillar. Once we are starting our case, we have to focus on the aesthetic. The aesthetic, it is intraoral. We are not only focusing on the intraoral alone. We have to focus also extraoral, then combine the extraoral with the intraoral both together. So how we can do that? Of course, we have some horizontal lines extraorally and vertical lines. The horizontal lines are going to help us, as I will explain in the upcoming slides, based on the case of Ms. Hiba. The extraorals, they are horizontal and vertical lines. Each one is responsible to help you to determine, determine a treatment planning part based on some landmarks. For example, once we are coming to the horizontal lines, this interpupillary lines, which is, if you get back to the previous slides, here you have this line, and this is the combination between the horizontal interpupillary line, which is combined between the skull, the upper part of the head, then the lower mandible, which is the mobile one. That is very important. How can I practically do that? By joining this line, this point, with this point. Then we have a line. After that, we will combine with the incisal plane and then to the occlusal plane. This is an aesthetic transferring of the external landmarks to the intraorally, and to respect to combine between aesthetic and function. That's why starting with the facial, it is important, because once we have a case which is not coincide with the external landmarks, we will not give our patient a pleasing feeling regarding to the aesthetic improvement. So what else we have to focus? Of course, we have to focus on the tooth position. One of the big points we have to focus is the tooth position. For example, if you look here, is it inclined buccally or retroclined lingually, or it is in ideal position? The position also, it is related to the upper lip, and also to the lower lip, and also to the lower anteriors. Of course, the horizontal jet should be considered. The vertical jet as well should be considered. So the position of the teeth all together is very important to be checked. Then you come to the gingiva. Then you come to the papilla liver. So you have some rules. For example, we will come to the rules, but we have to start with the teeth after transferring the external landmarks to intraorally, then to focus on the tooth. Is it buccally located, incisally? How's the incisal location? Is it too away of the lip, or touching extended beyond the borders, or it is retroclined, or it is axially inclined, for example, to the other side? Because we have many concerns regarding to this issue. For example, let me explain this point. Once you have a central incisor like that, and you have axial inclination, this axial inclination, once it is inclined to one side, for example, to the distal or to the mesial, if it is even 1 milli, it is more clear than if you have a shifting of the upper dental midline with the facial midline. So axial inclination is very important to be inspected before going to the other issue. So what we did for our case, it is a combination, let's say, transferring of the external landmarks. This is by interpupillary line with the occlusal incisal planes. Why? Because it is very important and it affects the whole treatment modality. Then, we have here a very important point, should be respected. Once we are trying, if you get back to the point, what we say it's facially generated. So we're transferring some lines, then we come to the tooth position. One of the area of the tooth position, it was incisal tooth, incisal liver. What I mean regarding to the incisal liver? Incisal, it means you have this tooth. This is the patient with the full smile. So when the patient when in rest position, he does not have a pleasant smile, and here his teeth, they are not giving him a youthful smile. They are not appearing. This is the maximum smile. Maximum smile, if you have this amount of teeth of incisal display, he looks like more than 10 years older than himself. So it is very important to pay attention for this point. The rule is, once you are in 30, if the patient is female, 3.4 million, or we can say relatively 3.5 million at rest position, the incisals should be appear. For this guy, around 2.5 million at 30 years old, the incisal should be displayed. In which position? Once the patient in rest position. How we can recognize the rest position? Of course, we have to instruct our patient to say, to pronounce the letter of M. Then we can detect the position of the incisal area regarding to the lower, regarding to the upper lip, and regarding to the lower teeth as well. So it's very important to start with the external landmarks and to transfer them intraoral. Then, once you did that, you come to the intraoral features. Sometimes some authors are enumerating more than 12 landmarks of the intraoral guidelines. So we have Dr. Ayat, I will try. Okay, thank you. So we have to focus on all the landmarks to respect them, because we say that it's a treatment, but a treatment is based on the aesthetic rules. Okay, how we can start? After determining the incisal display, simply we stated, then we come to some other rules, which is the height, which is length and width of the patient. It's for the central incisors, very important to be considered. Then after that, we will come to the golden proportion. Then we will come to some soft tissue parameters like zenith point. They are very important to be considered. Then axial inclination. So I will explain one of the rules practically, which is the width and length determination of the two central incisors. They sometimes called macro elements. For example, this case came to our clinic. She was complaining of this big space, which is here. She was asking to do some veneers, as the common termination is, or they are calling it in our country, in Kurdistan, they say hold with smile. Okay, so if I come to do some veneers for her, of course, this central will be very big. So the width will be wider than the length. The width almost will be wider than the length. So it's not treatable in this way. We have to respect this rule. Then after checking the width, this is the width, and the length of the centrals, it means we will go beyond the normal proportion, which is 85%. This rule is very important to be respected. For people who's familiar with the rule, it's okay. For someone who's not familiar, I'm going to explain a little bit about it. When you have two central incisors, you have to consider this length and then to the width. The ratio of the width to the length should be in between 75 to 85%. So it means when you have a length, 10 millim, suppose it's 10 millim, the width should be in between 7.5 millim to 8.5 millim. This is as a general rule. Is there any situation I can extend beyond 8.5 or more than 7.5? Of course, we have some situation we can handle this situation beyond the normal range. But most of the people, they have to be respected in this ratio. Okay, if we apply this rule for this case, get back, if you see here, if you look at the 8.5, the width will be more than the length. So the perception for the eye will not be good. That's why we refer our case, this case, to the orthodontist to bring the centrals together to divide the space between most of the teeth. Then we will come to start with some aesthetic improvement. The case might need full mouth rehabilitation or not. But the aim here is for either full mouth or not, if the case not full mouth, we have respected the aesthetic rules, which is some rules inside the patient's mouth. Then, back to Ms. Hiba, what we have to do in this situation, look, we have to again to come to the incisal display. It is very important for the incisal display. For the males, it's around 2.5 millim. For the females, it's around 3.5 millim. After pronouncing the letter of M, this will be the first point, the cornerstone, how we divide, how we start our treatment for our case after assessing of the extraoral landmarks. For example, this picture from this book, they are testing the incisal display. The patient does not display any incisor. There might be less than 0.5 millim. I'm not sure. And also, this is my case. Again, we were trying to expect the, let's say, to evaluate the incisal display. And this is the rest position, which could be achieved by pronouncing the word of the letter of M. Then we have to after assessment, we have to put our guidelines. Let's start our case based on the incisal display. Suppose this case is 30 years old, so we can add here 3.5 millim. We have many rules. We have lip length, we have maxilla and teeth, we have incisal display itself of the patient, width and length ratio, anterior guidance, envelope of function, condylar eminence, occlusal plane, age of the patient. Many rules should be respected while we are doing this work. But here, I just want to assume a scenario for the case. If our patient is 30 years old, and we start to put here 3 millim, because we want to get 3.5 millim. So once we have 3 millim here, we have to respect the envelope of function. I will share with you some slides. Once we did our expected the incisal display, we connected with the function, which is the anterior guidance, horizontal jet, and lower teeth. Then we can mark the exact amount of tooth of the increased incisor. This is the same talk that I was talking when the patient, when she is female, at age of 30, around 3.5 millim should be displayed. Here, male is 30, 1.57 to 2.5. Almost it's 1 millim. Females that they are 1 millim shorter. 1 millim shorter. Males, I mean, they have incisal display 1 millim shorter than females. This is as an average of the case. If you look this patient, this is before working. He was more than 50 years old. This is after full mouth rehabilitation. How much the incisal display transformed the patient's face from an elder patient to a youthful face. This is the same for another patient. What we did here, she was having this incisal display, and I did only 2 millim compost immediately, and here 4 millim. Regarding to the aesthetic, she was trying to have this 4 millim. So what I should do, I select this one. But if I place 4 millim on the anteriors, and if I get to the 6 or 10 anterior, of course I will have impinging, interfering with the lower teeth, and it will be interfered with the chewing, with the speaking, with many issues. So what I did for the patient, I increased the bite. So I finished the first rule, which is aesthetic. Then I will come to the second rule. As you know, we don't have much time to go to the detail. That's why I will go a little bit quicker for the function. For Ms. Hiba, we have to inspect the TMJ, temporomandibular joint, occlusion, and muscle. She was having headache. She has been diagnosed with the migraine. She was having attacks every 10 days, one time, 2 weeks, one time. Then we checked. After we checked her muscle, TMJ, and occlusal contacts, you will see. First of all, if you see, here we have a shifting of her mandible. Clinically, you can see without using any tool. If you have advanced tools, of course, it helps you to diagnose the case much more better. So if you look here, very simply, you can see the patient is suffering of what? Of shifting. Look to the left side. And it's almost the late shifting. And then if you come, simply check this picture, midline, both of them, then open take another photo with open, you feel there is a slide. This slide, it means the patient has shifting, and the shifting is maybe patient feels some abnormality or some pain, or she might not feeling any pain. It related to either it's extracapsular, intracapsular. We cannot explain these points here. So first of all, for the diagnosis of this case, it is very important to fix the fundamental of occlusion. The first one is the healthy of the TMJ, of the muscles, and also of the three very important rule of the occlusal contacts. So this is the first step of Ms. Hiba. Then we have jaw motion analyzers we are using for some critical cases. This is the jaw motion analyzer. It helps us to diagnose the case much easier. It tells you the situation of the case in numerical data. So we use it the patient, but conventionally also we get to the articulator after recording the centric relation with the face bone, and then we tried to have some. For example, if you look here on the articulator, this is initial without any problem. Without a minimum tooth contact. This is in her centric relation. Okay, this is the some contacts. So what we did for the patient, of course, we have to record the centric relation, then transfer the recording to the articulator. Then after checking the articulator, one point is very important here. We have to check intraorally, as you will see some slides. Intraorally, it should be coincide with the articulator recordings. So it means we have to record some contacts here, then we have to compare with the intraoral contacts during the examination, because we have to take some photo, then they should be matching. These contacts should match the intraoral contacts. Then it is very important to check the anterior guidance. And intraorally, as I mentioned previously, we have to look at the cusp fossa contact. And with the digital tools, you have a better visualization of the case. We are using both of them, combination. Then all sides. Here the case, look at the main contact here, contact here, little contact. And on the cast, you can see a treason here. So first of all, the contact there is no maximum contact with the maximum tooth surface. We have very little contact with minimum teeth surfaces. What I have to do, of course, first I have to do some teeth grinding. We have many details regarding to the teeth grinding. I have to do based on some rules. Here is I was doing here contacts with myself. Sometimes my team is helping me, and for some critical cases, I try to do by myself accordingly. Then after we remove it in a few steps, we could have, if you look here, we could have many contacts. The contacts increased. This is for the biological tooth full mouth rehabilitation. This is one of the big points to enhance the occlusal contacts. If you look before, this is before, and this is after. They both upper. You can see heavy contacts here. This stage has been done before touching the patient's teeth, because we have three scenarios in case of the selective grinding. Sometimes after checking on the articulator, you realize it's impossible to do in patient's mouth. It is beyond the ability of the selective grinding. Sometimes it indicates the selective grinding. So accordingly, either it's selective grinding or full mouth rehabilitation or orthodontic treatments. For the lower as well, we increased the tooth contact here. It was the previous, but we increased it. And here as well, if you compare with the after, we have a better tooth contact with the first step of the teeth grinding. So what I have to do for my patient, the first phase bow that we recorded was for the treatment plan. Right now, we are going to record another phase bow recording to the conventional occlusal splint. And then after occlusal splint has been fabricated, we have balanced the occlusal splint for the first time. And then for many follow-ups, we are following a special concept regarding to this issue. So it is very important to deprogram the case and to prepare her for the full mouth rehabilitation, especially when the patient complaining of some problems in either TMJ or muscle of mastication. So after grinding, we have detected as well some counts. If you look the patient, we checked the phase bow and interpupillary line, but you can see some count. But when you have this count, you have to pay attention for the treatment planning. The count tells you many points. I marked for you 1 point. Look, here is the contact of the line, horizontal line, with the premolar. Here's the canine. Here is with this canine. The right side, it's a tip of canine, while the left side, it's not. So we measure this tooth. If it is, for example, let's say it's 8 millim, and this one is also 8 millim. So it means teeth are equal. The problem, the discrepancy, either from the skeletal or from the lip or from something like that. So we have to check the balance between right and left after correlating with the external and internal features. Then for the case, we came to the, of course, to check for every case, to check the evaluation range of motion, as I shared some slides with you. And quickly, I will tell you the story of this patient. She came to my clinic. She was having the problem in this central incisor. What we did for the first time, we did a direct compost for her. Then after, it is 7 unit porcelain laminate veneers. Then after 1 year, she came back. She was suffering of this chipping. Then again, after 2 years, the chipping increased, and also here is the cohesive failure of the ceramic. So I checked, I could detect the patient needs selective grinding and also orthodontic treatment, because she was having a very minimum amount of the horizontal gel. So after that, we repeated 2 centrals, and right now she don't have any problem. Back to Ms. Hiba, the same thing here. We are checking in this video the pattern of chewing pattern, because as you know, we have horizontal chewing pattern, horizontal chewers, and we have vertical chewers. For the horizontal chewers, we have some special rules. For the vertical chewers, we have some consideration that's related to them. For everybody, we have to detect our patient. Then we come to the GTS as well. It helps us to check the interference of the contralateral size and also the chewing pattern of the patient as well. After checking all the issues, we are coming to the structure, the third part, which is very important. Do we have any compromising of the tooth or not? Do we need any replacement or not? Or teeth wearing or not? Does it need restoration or not? We have loss of tooth or only a part of the tooth. So many issues should be respected. Again, we were explaining some points regarding to the gingiva. We don't have time as well here. So we have to check the biology of the TMJ, of the muscle of mastication, and also of the, if you look endo, vitality of the case, perio, bone recision, or the volume of the bone, interproximally, everything about the perio. Oral surgery, do we need any intervention? This is very important. The airway recently has been involved in the treatment of the cases, in every case, especially ortho and full mouth rehabilitation. We should pay attention for this issue, and it is considered as one of the component of the biology, and which is biology is the fourth pillar of the full mouth rehabilitation. So generally, when we are treating our patient, we have to check the aesthetic, we have to check the function, we have to check the structure, we have to check the biology. We are going to implement the rules with the case of Ms. Hiba. So if you look here at the patient at the beginning, our protocol, we are following this protocol, which is DSD and Facebook. They both helping us to enhance the treatment planning. Then this is very important for the recording of the measurements for the centric regulation, centric occlusion, to assess this issue, then also to count practically. And if you look here, we have a mismatch between the midline, upper and lower, and also as we stated, as we explain it, we come to the rules of the aesthetic and rules of the biology, and then after we have to pay attention for the gingiva. So first of all, get rid of the calculus, try to control the gingiva, then you can go ahead. By the way, for this patient, for the occlusal deprogramming, occlusal adjustment, and gingival treatment, I think we have spent more than 3 months for the patient until we could control the previous mentioned points. So here is the patient in the photos in the all sides. It gives us a lot of the information, again, to the intraoral. Then the video here is not the video of the case, just to explain. We send it digitally for the laboratory, and they are doing a mock-up for us, and we have to check the mock-up before any before any intervention. Personally, I do prefer to check the mock-up before receiving back the mock-up because it helps me to highlight some points on some area which I cannot see inside the patient's mouth easily as I can say in the mock-up. So here is the patient with the mock-up. After putting the wax up to the mock-up, the patient, we evaluate the patient aesthetically, functionally, and of course, some letters in every concern. If you look at the patient here, this is the mock-up. We are using this mock-up after for this patient, after deprogramming with the occlusal spleen. We use this mock-up again as a tool to diagnose the patient or to check, to assess the situation. So the patient 10 days, sometimes 2 weeks getting back home and we're checking, then we are following some criteria. For example, is there any debonding? If the debonding happened in which side, then you check why this debonding happened, because of the range of motion, because of the functional problem, or because of the imbalance of the occlusal contacts. So it is very important to check the incisal display for the patient. Fortunately, we could control the incisal display by respecting the occlusal, functional, and aesthetic rules, and combining with the patient's preference. Because patient is not a banana here, we have also to respect her idea. She is coming to improve her smile. Okay, for us, function and biology is more important. But eventually, we have to come with some aesthetic improvement that satisfies her mind. Okay, one point is very important. If you look here, this area is called neutral zone. So in the natural human body, the teeth, the position of the teeth should be like that. What we have here is the horizontal jet, and the tip of this one to tip of this one, what we have is vertical jet. So this one should be in some range. For example, horizontal in between 2 to 3 millim, vertical in between 3 to 4 millim. Okay, so how we can control this area? In the beginning, initially, the patient will come to you either with a normal, acceptable situation or with abnormal. So we have to know, once you have a patient with teeth wearing, either incisally or buccally, aesthetically, there will be a compromising even of the lips. To enhance the youthful smile, what we have to do, we have to increase the length and sometimes combine with the buccal thickness. It is multi-advantageous, but one of them, if you look without filler, the patient will get some improvement of the lips, which gives her more, it enhances the smile to be youthful. Sometimes I'm kidding with my patient. I tell them, especially female patients, I tell them, I can, I can give you a perception of 5 years younger smile to you. Of course, you will see in the end of the same webinar how we improve the case with this youthful smile. Then we are checking. We have to control many details in the temporary. Fortunately, we have this detail in every part of our full mouth rehabilitation in our upcoming long-term course, which of course you should be informed about this course. So if you look here, we have we controlled the detail because it is very important to be biological. The temporary is not giving you aesthetic. It has many concerns: aesthetic, biological, functional, even for the pronunciation. And psychologically, if the patient is get benefit for the treatment for this temporary. So we are after 2 weeks, 10 days, 3 weeks, patient again will be back to us. And we're starting our treatment. Here is very important to pay attention for the structure of the tooth, because once you have this conservation tooth structure, it means you are elongating, extending or enhancing the longevity of the patient's form. So it is very important to be conservative. Personally, I use microscope since 2000, the February of 2017, and without microscope, I cannot work. To be conservative, if you look, this is lower anterior, and I was a little bit here distracted because of the minor crowding, but you will see here how I was minimally invasively working for the patient. Then intraorally, we were trying, you will see here, even during the work, after the preparation, this picture is after preparation, we are coming to check the balance of the soft tissue again, taking a photo and putting on the DSD, checking the balance of the soft tissue before going to placing the first cord. So it is very important to pay attention not only for the precision or the conservation of the tooth structure, the balance of the soft tissue also should be. Even I was working here, respecting the zenith point, all of them, once I'm molding the soft tissue, I have to receive back the normal shape of the soft tissue as much as possible. So we finish it very conservatively. Then it is important with the laboratory to send this to the MD shade guide, the stamp of the prepared tooth. For example, if you look here, it's mostly ND1. But our team, they are very smart. They're giving ND3, ND2 sometimes. Why? Because they're giving our laboratory idea to handle the aesthetic color transformation. And in spite of our laboratories beside our clinic, we are recording pictures because the patient is not in the laboratory. The patient will not go to the laboratory. So we have not to leave anything for the chance. So coming to the step quickly, what we did upper treatment, then lower treatment. This is the after treatment, then scanning with the digital scanner. Rarely we are using conventional technique. Since 2018, I am using intraoral scanner. For the single tooth prosthesis is very promising. It's very helpful with a accurate transfer recording. I have many tricks regarding to the impression, either conventionally or digitally. Unfortunately, we cannot share here right now. Again, we can do that with our long-term course in Istanbul. Then we come to the temporary. The first one was mock-up. We use it as a temporary. We can use as well as a temporary, but for this, sometimes we are using milled temporary. This milled temporary, it helps us to check the precision of the designs, and also it helps us to, they are much more finer because of the interproximal area. So we have many benefits of this temporaries, which is milled. We are bonding with a spot itching technique. Then after that, patient will get back to home. If there's any problem, we follow, and we are assessing the situation in many point of view. We come to the try-in. The patient, if you look, first try-in, second try-in, third try-in, fourth try-in, fifth try-in. And she was saying, no, I'm 20 times came to here. In all our cases, we pay attention for every detail. That's why we said we have to integrate between aesthetic function and precision. So let's have a look for the try-in, for the how we do. First of all, once we receive back, our team, they are doing on the cast. They check on the cast, and they check that there's crack, fracture, anything, regardless of the patient. Then after that, second time, when the try-in, which you received back the case, we are checking again intraorally in the patient's mouth, individual, every tooth individually, then with other tooth. This is for dentists. This A individually and B all together. Third stage for combining aesthetic and function, let's say external landmarks with the teeth volume, position of the teeth. And last time, after placing rubber dam, as well we are checking. For example, if you look here, we are checking the tooth first time individually to check the whole sides, the fitting, and also finish line. In the second part, if you look, we are checking this one with this one together. Under microscope, sometimes you can see some very micro mobility, and then during the cementation will get hard because of the difficulty. So trying is very important. We are appreciating our patients' comment because sometimes you cannot see something because some patient they are. I can't accept in my team to say TM. They are not TM. They are detailists. They're paying attention for the detail. They have read many things about the aesthetic rules, so they have their own code. We have to respect them. I appreciate many times I learn some detail from my patients. At least they remind me. So we are checking everything. That was the first trial, and this one I think it was the last trial. And we are checking here. If you look, the incisal display, regardless of the lower teeth, we check the incisal display and all the rest of the rules because it is very important to be respected. Then, when the patient done, this is the last try-in, as I mentioned, intraorally. If you look, what we are doing, we are checking the under rubber dam and inspecting with microscope. We are checking a very little, let's say, a micro detail of the patient for the patient because we think we have to pay attention for this detail. Then here is the patient. Here, Ms. Hiba before working, and here is after working. Fortunately, the case now I can say excellent. But what makes me more happy is not the external surface or the aesthetic achievements. She was suffering of the migraine. After increasing the bite, after achieving the whole, let's say, goals, I can say 98%, what we could do, what was, let's say, more for me was make me happy more was her migraine. The migraine is done, and she was after her last a few I think 10 days ago she came back to us. She said it's been more than 3 to 4 months after the treatment. I don't have any attack of the migraine. So treatment planning is very important for the patient, and executing of the detail is also important. It helps you to improve the patient's health, not only intraorally, it helps you to the extraoral, and into some degree, it helps you to enhance the airway of the patient. But I can give guarantee for such patients. Of course, I don't tell them without any problem. I can say life expectancy more than 15 years. Why? Because I controlled the occlusal contact. I was minimally invasively working. I protect the enamel. Then the enamel is going to enhance the age of the prosthesis. After combining and integrating the aesthetic and function together precisely, of course, I can surely tell my patient you will have more than 15, sometimes 20 years life expectancy with respecting of some minor problems. Then, before ending of my webinar, I think my time is going to end. I want to tell you, I want to share 2 other cases very shortly. The detail of the cases could be shared in our upcoming event, CART, long-term course in Istanbul. This is another case. She came to my clinic before 3 years, and she was seeking for aesthetic improvement. While if you look, we have some problem with the skeletal and also with the position of with the teeth, which cannot be improved with the full mouth rehabilitation. So we send the patient, we referred her for the orthodontist. This is after orthodontic treatment. Fortunately, we could achieve this result. Then after orthodontic treatment, I use it. This is the patient after treatment with a biological approach. And the important point, one of the most important point that I cannot highlight in detail here is the sandwich technique. Because she was, if you look back for the first picture, horizontal jet is too much. Once we are trying to improve her smile with ortho, our orthodontist said, I cannot improve the whole because of some consideration. I don't know about ortho. So he left some space in between upper and lower central incisors, palatal of the central and buccal of the upper. So what we could do here, we could improve this space by the sandwich technique. Sandwich technique is not the sandwich that we are eating in our life. It is a combination between the palatal and buccal veneers. So it is a very critical and sensitive technique. I hope I can share with you in another opportunity. So this case, the detail of the case, I'm going to share with you in the 2 days course, the long-term course, 2 days, which is only full mouth rehabilitation. Then the last case is this case. He came to our clinic. If you look, this is maximum smile. He has a very little incisal display. And beside of that, he has congenital missing of lateral incisors. So also implant and full mouth rehabilitation with bite raising. Without bite raising, we cannot improve the smile in this way. So fortunately, we could have this nice and integrated smile. So we can say we could improve, we could achieve the biological model of a successful work. This is the story of my webinar regarding to the full mouth rehabilitation. We have many details. I hope I can see you